this topic is a topic you've all been thinking about, and that is this construct of CP. Well, I started thinking about it quite a while ago, and when I just published a paper called Reconstructing Cerebral Palsy in 2004, I got an invitation from Martin Bax to a meeting he was organising together with Murray Goldstein and some of great people, quite a few of them are actually in the room right now, and the idea was to redefine cerebral palsy, to update the Bax 1964 definition. Of course, there had been definitions in the meantime, and the idea was relatively shortly after the ICF, see if things had changed. Now, CP has some history, but the history is not very long. People like to start with a painting or with Shakespeare. That's a great classic. They cite King Richard III, and they take that bit which says cheated of feature by dissembling nature, deformed, unfinished, sent before my time, taken to be an allusion to preterm birth, possibly into this breathing world. You have the perinatal respiratory problem, scarce half made up, and that so lamely and unfashionable that dogs bark at me as I hold by them. And so many of us has cited this as evidence, and a very poetic description of CP, but it is mostly poetic, and I don't think that it's really CP. So it's very strong in the literary term. And what was interesting was that when people were digging to build a parking in England, they did find the skeleton of Richard III, and there was a nice case report published in the Lancet entitled The Scoliosis of Richard III, Last Plantagenet King of England, Diagnosis and Clinical Significance. And they illustrated a scoliosis quite nicely, and their conclusion was quite firm that it was adolescent onset idiopathic scoliosis. This is no criticism of Shakespeare, it's just a refocus on the more modern history of cerebral palsy, which really starts with Dr. William Little, his series of lectures given in London. So Dr. Little, as some of us know, was interested in clubfoot, had written a treatise on clubfoot. He himself had foot deformity, but then that was really a big start when he made his colleagues aware of a condition that we still describe today as cerebral palsy. For a while it was described as Little's disease. There was much discussion at the time between the likes of Freud and Osler, who said that the condition did originate in the brain, whereas people like Charcot, Freud's master in Paris, and Erb in Germany argued that if you have a bilateral presentation, it had to be from the spinal cord. So eventually Osler and Freud won the argument, coined the terms cerebral palsy or cerebral palsies. Freud cerebral diplegia, cerebral diplegie. And so if we project ourselves, when I first met Nigel Paneth and that meeting in Bethesda, the theme was how we were to define cerebral palsy. The first day of the meeting was very interesting. Many people came to the platform and explained their views, and there seemed to be an emerging consensus by the end of the day that perhaps we shouldn't be talking about cerebral palsy, and it might be more interesting to define a broader condition of developmental disorder. So something that would really emphasize development, that would emphasize also not only the motor aspects but also the extra motor aspects, and that would include not only what we call cerebral palsy but a host of developmental conditions. At the end of this first day, Mary Goldstein came to the microphone and said, well, I'm going to say very little, and perhaps this is the only thing I'm going to say. Can I just ask that you keep the term cerebral palsy? You define it however you can, however you want, but please try your best to keep the term cerebral palsy, because this is a term that people know, have known. This is a term that has been used for research, and we have an accumulation of findings, and it would be nice to be able to use them in the future, and mostly because it wouldn't be fair to jeopardize service but also funding of research that is based on this label. This was a very interesting point. We discussed it, and we decided that we would try the exercise. Now, it was also an ambition to have a definition that would serve many different people's purposes, so both clinicians and scientists, and we would have epidemiologists, basic scientists, but also people outside our domain, and that is policymakers and, well, many people, including users, as we said at the time. It's based on an ideology that we can all converge and have a term with a definition that would work for everyone. And the definition, we had a first version of it, we proposed it to the community, there was some reaction, some people were actually very cross with some of the choices that have been made, and there has been really constructive discussion, and eventually the current definition was published by a group, and the first author is Peter Rosenbaum. And what we did is a definition in 2 sentences. The first one being a semantic update with emphasis, modern emphasis on things that we thought were really crucial to previous definitions, including Martin Bax's, well, I say Martin Bax, but so it's his name associated with it, but it's also consensus work back in 1964. And then a second sentence explaining that CP is happening in a wider clinical context than just the motor aspect. So it went like this. It says, cerebral palsy describes a group of permanent disorders of the development, that was also very important, of movement and posture. We couldn't decide if we would have one or the other, so we kept both. Causing activity limitation, this was vocabulary directly borrowed from the ICF, which would exclude, for example, clumsiness, which was an entity at the time, that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. Then the second sentence was the motor disorders of cerebral palsy are often accompanied by disturbances of, and then a host of examples: sensation, perception, cognition, communication, behavior, epilepsy, and by secondary musculoskeletal problems. So a host of manifestations which could be primary together, so attributed to the same cause as the motor problems, but could also be secondary to the alternative developmental trajectory imposed by the motor problems. It's interesting to note also that the motor disorders also have this secondary component. This is more conceptual. This is not something that you can really measure. But if you take the visual problems, that's a good example where you can really see often, say in preterm baby, lesions along the visual pathways, just as you can describe lesions along the motor pathways, and that would be primary. And then because of the alternative set of experiences, which is more constrained, you can have secondary visual problems of perception. And then there is some time that has elapsed, and in the past few years there have been more propositions to sit together again and think of a more up-to-date definition. So some ideas came, for example, from Canada, suggesting that cerebral palsy should perhaps be considered as a spectrum, and the idea was that this would better reflect the heterogeneity of cerebral palsy, if we call it a spectrum, with the subtitle or the undertext would be that no people with cerebral palsy are really the same. It might be interesting. It's actually been done for other conditions. I think it's open for discussion. It does have a different history than take autism spectrum disorder, where the spectrum is more the conflation of presentations that were regarded as separate, and at a certain time people say, well, maybe it's interesting to see them as a spectrum, to better see the continuity between all those presentations. So I do think it's quite the same as the autism spectrum disorder, and I think that the argument might be interesting, but has its limits as well. I mean, many conditions, and possibly all conditions, do show this heterogeneity, and one might be tempted to talk about migraine spectrum, multiple sclerosis spectrum, just any or stroke spectrum. And it's clear if you take stroke that there are many different presentations, many different etiologies, causal pathways, patterns that can be identified. So if you want to move to that terminology, it might be good, but I think we must make sure that we still describe individuals. There was also the proposition to use the plural form, and some of my colleagues do still say cerebral palsies. That's also okay. If you are to describe which are the different cerebral palsies. Some people have done that for other conditions, say the epilepsies, for example. I must say, in my practice, in my reasoning, in my research, I don't think that that's all that necessary or really helpful. What I think is more central is to make sure that you can have appropriate categorizations, and functional classifications, for example, have proved very helpful, and there are of course other forms of classifications that would suit different purposes. So recently I have been invited in groups that said that they wanted to redefine cerebral palsy, and perhaps suggesting a more operational definition of cerebral palsy. That would be interesting, and if you think of the notion of the spectrum, one of the difficulties with the spectrum might be the cutoff between a normative situation, and then when you are stepping into this spectrum. So it might be useful. For example, there's very little literature comparing DCD, developmental coordination disorder, and cerebral palsy, and possibly it might be good to have, say, a test that says, well, we on this part of the fence or we the other side of the fence. The thing is that neither DCD nor CP exists as a firm thing. I mean, and this is the case with almost all diagnosis. A diagnosis is always a construction, and what's really interesting in this choice here of still having cerebral palsy or DCD for that matter as a diagnosis is the idea that you're offering a description, that you're not making inferences about cause, and so you always want to assort it, if not with an etiology, at least with thinking, a search for the causal factors and a hypothesis as to etiology. So I think that it's good to have a description, something that might explain the situation, and some idea of classifications offering some ideas of generalization, and also of reduction of the complexity into more useful constructs. Now, how useful and to whom? When we think of a diagnosis, I tend to think of a diagnosis, a heart attack, and then the clever diagnosis that you would make is a construct within a current knowledge of physiology, which you're going to use to be helpful to the person. So here, who are the stakeholders, and so who does the diagnosis belong to, as it were? I like to think in terms of dimensions, as we hear, as people think in terms of science, and I would say a scientific dimension. And the scientific well, it's not the only one, but I'll start there, and this a bit arbitrarily and well, possibly a personal bias. So a diagnosis would reflect heterogeneity. We would have discussions about inclusiveness, over-inclusiveness, under-inclusiveness. We want it to be reliable in the way we use it, our colleagues use it, and we want it to serve communication, so to have a common language, both to describe and to be able to investigate further. I think that's what we want, and is it useful? I believe it is. I believe it is. It's interesting how little we have in terms of animal models for cerebral palsy. I mean, we certainly have animal models for mechanisms, but that is thanks to this approach, how we view cerebral palsy and how we think first of a description and then of risk factors, causal pathways, and then we can go and study making models, including animal models. But beside science, there's certainly other dimensions. Well, again, sorry for this egocentric bias, but the clinical dimension is well, there's some overlap, but I think that is still separate from the scientific dimension. And there we want a diagnosis like cerebral palsy to help us understand, but also to help the patients understand and the families understand the condition as we retell it. So people come to us with a problem, with questions, with a difficulty, and we try to help them by tapping into our own current knowledge, and we reformulate some of the problems. We filter them out to fit within our clinical model, to offer some explanations that will help make sense of what's happening, some sense of what's happening, make projections into the future, and crucially to build up design management and see how we can follow up the situation. There's much more to say about it, but this is what I'd like to say at this stage. So we said scientific, we said the clinical dimension. There is a social dimension, which is certainly not to overlook, and there again communication is very important, because it helps us crystallize some complexity into a form that hopefully can be explained. So we can provide information, we can provide also information about special needs as association between, we say, well, for example, cerebral palsy or that form of cerebral palsy, and then you set a sort of context. There's also a risk in our social use, or in the social use of labels such as cerebral palsy, and this is stigma. So we tend to create stigma, we tend to perpetuate stigma, and this is something that we should really have in mind and see how we can better address. And sometimes we can go beyond, thanks to the fact that we said, okay, here we are, and we can lift some barriers. Possibly a fourth dimension relates to service organization, and that is very often an administrative dimension. We use labels such as cerebral palsy to help people with claims, to obtain funding, to organize service, and this is of great practical importance. It also has some issues with pressure that may be placed on professionals, and in particular on people making the diagnosis, and a tension between, well, perhaps they might be too inclusive because they would see that people are in need of certain services and it might be borderline, or they might not correspond fully to a diagnosis of CP, and there you have those ethical issues. Interestingly, when we talked about age for cerebral palsy, so we insisted on the fact that it's developmental, but we resisted putting an age limit. And in the discussion, there was very clearly the fact that we didn't want such a limit to be used against the best interest of people with cerebral palsy. So again, this is open and certainly should be discussed. What we did with this definition, and that was great joy for me, because I did some of it, quite a bit of it, was an annotation. We called it Rashi between us, so like a comment on each of, I think it was 19 words, saying why we say cerebral, why we say palsy, why we say group, why we say permanent, what do we mean by, say, attributed and disturbances, and so forth and so on. So this definition, which has been put into question recently, has aspects that I did really like. I think that it would be important if we were to update a definition, first of all to wonder if the concept is still valid, if it's still important, if it's still relevant. We should be talking about the name as well, so is it cerebral palsy? And then we should also have an emphasis on aspects that are certainly there implicitly. One is the emphasis that cerebral palsy is a lifelong condition. Another emphasis that I would like, it's not there explicitly, but this definition is supposed to be descriptive for situations encountered across the world, is the realization that we do increasingly that many more people with cerebral palsy live in low and middle income countries than in resource-rich settings. This is obvious, but it's not so obvious from much of the thinking and much of the research and the data that we have to build on further knowledge on cerebral palsy. So this is a second aspect that I would like. And then the third aspect is with regard to the ICF framework, so this framework, the International Classification of Functionality on Health and Disability, Disability and Health. That was certainly on our mind, but I think, so personally I have a better understanding of the implication and the view of the ICF now than I did then, and I find that the definition is still very much biomedical. And you see that I still carry those biases. I started with scientific and then I went to clinical, and then only did I go to social, and I didn't even talk explicitly about the individual. And I think that the individual experience is something that is really crucial. So what I did recently when I was involved in discussions at the AACPDM and other groups on trying to redefine cerebral palsy, I realized that the methodology should be different. I mean, we should no longer have the methodology that we had back in 2004, or if we have the methodology of 2004, at least we should have more diversity around the table. We had, I think in 2004, 38 experts, or 37 myself at the time. Since then I've learned enough to get invited to such meetings, but at the time we were mostly representing high resource settings, and when I say mostly, it's not to say exclusively. I think there was possibly one person. So we clearly had underrepresentation or no representation of many parts of the world, and I think this is not fine. And I think that we should have big representation of people with lived experience, either people who have cerebral palsy or people with experience of looking after someone with cerebral palsy, not from a medical or therapeutic point of view. So I stopped those discussions and I told the different groups, you know, I would like to go to people with lived experience from many different countries and know what they think. And I thought one way of doing this was to organize a meeting with people from the International Cerebral Palsy Society. And I had meetings, and one big meeting, and that was very interesting. First of all, very interesting to see the interest, how many people there were around that table, and it was a table like the one I'm sitting here. I mean, we were also video conferencing, and I asked them if they think that the definition needs updating, and if they're happy with a concept of cerebral palsy, if they need that at all, and if they're happy with the wording. And so they basically, and I'm synthesizing a lot of input, people from the ICPS, International Cerebral Palsy Society, seem to have a consensus around the fact that they wanted to retain cerebral palsy. Now, of course, this might have bias, and this is my selection bias. I went to a group which is self-defined or self-referred as CP, so ICPS. So there's certainly an issue there to consider. So they said they were happy. We did talk about the term cerebral palsy, and then we talked about the content of the definition. And they said that what was important to them was not so much the term, but it was to have a useful definition. And to them, a useful definition is a definition that represents them. And what they meant by representing them was that shows very clearly that the condition is very heterogeneous, that you can't make a caricature and you have one pattern, and this is cerebral palsy. Another thing they said is that it's important that people realize that it goes across the lifespan, that many people still think of cerebral palsy as a pediatric condition, and so they're surprised when they see adults with CP. And they said that should be more explicit. And third aspect that they wanted is a clear explanation that their brain was not dysfunctioning, because some of them were saying either about themselves when applying for a job, talking about themselves, or about their children or relatives, that there was a lot of prejudice, and people were convinced that the brain was just not working fine, and for people it meant much more than the manifestations that there were at hand. Then we talked about the word cerebral palsy. So you remember that Marie Goldstein asked us to keep the term cerebral palsy, and it's interesting because palsy is actually quite obsolete. Possibly a handful of conditions in medicine, possibly not even that, where we still say palsy, say Bell's palsy, Erb's palsy, and perhaps one or two more. But we don't say about a patient, about a situation, that there is palsy, that the person has palsy. But that didn't seem to, it did bother us, but it didn't seem to bother people. And then we talked about how cerebral palsy translated to different languages. And then you have stories there. For example, in Israel, they use a term, they say shituk mochin, and in it, so mochin is an archaic plural of brain, but it's not modern Hebrew, and so people who speak modern Hebrew would recognize that it's really an archaic form, and that is the way the people in Israel try to render the old hat way of cerebral palsy. It started with a journalist writing that in a big newspaper, and then it was discussed at the level of a Hebrew language academy, and this is how they say now. We had people from Sri Lanka. He said that they had a change in the Tamil language, also used in South India, to better reflect the causes, not just the cerebrum, but really have an emphasis on the motor disorder from the brain, so a wider term for brain. And then there's an interesting story from France in the 1950s, when people introduced the notion with a French language term. It was Tardieu. You probably know Tardieu from one of the tests used with different velocities for testing for spasticity. And Tardieu suggested a distinction between infirmité motrice cérébrale and infirmité motrice d'origine cérébrale. And so someone was infirm from the motor point of view because of the brain, cerebral, and other of brain origin. And distinction was based on apparent preserved cognitive functions, because Tardieu wanted to make sure that not all the children with cerebral palsy were excluded from the educational system. And so he said those with infirmité motrice cérébrale have intact cognition and they can be educated in his terms. Too bad for the others. So you see, all those years later, I mean, it's probably not tenable. And what the French did a few years ago, and actually shortly after this 2007 definition was published, they started discussing having a new translation from cerebral palsy, and now increasingly they use paralysie cérébrale. So the translation they used is no longer an old term like infirmité, but more paralysie, which is really the translation of paralysis. People from Argentina also came with an interesting story. They said also in the 1950s, so at the same time as Tardieu, there was an epidemic of paralysis infantile, so of infantile paralysis, and that is polio in Argentina. Really a devastating epidemic. And at that time, the clinical construct of cerebral palsy was introduced as a paralysis cerebral infantile, and that is so it's the same condition but emphasizing the brain. Later they just dropped infantile to render the fact that cerebral palsy is a lifetime not just for children. But what's interesting at the time is that it was important for clinicians and people in society to understand that there was a differential diagnosis to be made between polio and something from the brain, and that was CP. What people told me who live in countries where the translation of cerebral palsy used the modern term paralysis is that they feel that there is more stigma, that people understand as it were more when you say paralysis than when you say palsy, and really believe the brain to be paralyzed, whatever it means. But then it's like a more violent turn to it. And some people then told me that in a few countries, including someone from Denmark, said that there's a tendency to use just CP for cerebral palsy. And the idea of using CP is it's easy to pronounce, it's like universal, and it may help spreading information, not so much on the etymology as on what the term covers, and advocacy. And there was some discussion that this has been done for other conditions like ALS or MS. MS is a very good one. So both ALS and MS are much rarer than cerebral palsy, and many people know them as MS, and it has served, well, it has contributed possibly to making it, well, more popular, attract funding, attract awareness. And when you think of it, those terms are also outdated. I mean, multiple sclerosis is really 19th century way of thinking about neurology. And where are we? Well, I'd like to know what you think. If you think we should have a new definition, what a new definition should be, if it should be an operational definition, if it should be a definition with clear exclusion. There's a lot of discussion now about genetic factors, possibly easier when you have one condition which is clearly identified as non-progressive and affecting the brain and manifesting itself with something consistent with cerebral palsy, and all due to one gene. But we get more and more, thanks to genetic studies, more and more insights into, well, possible variants that might have a role there. So this is what I wanted to say if I was to come, and if I'd come, I'd show you pictures, art, references, but then I didn't master the technology, so it was either this or that, and this is what you got. So me was a bow tie and the accent. Thank you very much. I'll be there for the discussion.